Hi, welcome to week 3 of expanded function dental assisting. So this week we are going to be talking about a few things, but first up, occlusion. So let's get a little bit more into occlusion. Occlusion is defined as the static relationship between the incising or masticating surfaces of maxillary or mandibular teeth or tooth analogs. So like your models or tympanods, things like that. In order to restore proper function, you must be aware of the way teeth should come together. So this is what we're going to get into next. Proper tooth-to-tooth relationships of anterior and posterior teeth is required to maintain the health of supporting tissues and to allow patients to chew, swallow, speak comfortably, just function in general. Tooth relations. So there's a few different tooth relations we're going to talk about. First is intercuspal position, or ICP. It can also be known as maximum intercuspation, or MIP. This is the complete intercuspation of the opposing teeth independent of condylar position. It is determined by the way the teeth fit together and may or may not be coincident with the centric relation position of the jaw, which we'll get into in a second. Next, we have centric relation. So this is the location of the mandible when the condyles are positioned superiorly and anteriorly in the glenoid fossa. So the first one, ICP, is dealing more so with how the teeth are fitting together, and centric relation is more so about the mandibular bones themselves in the condyles. It's independent of tooth contact. It is a bone-to-bone relationship. So unlike ICP, it doesn't have to do with the teeth fitting together. It is the most repeatable position of the jaw as well, and any position of the jaw other than centric relation is considered eccentric. So you can see here in this picture, we're more so looking at the condyle position there. And then we have eccentric contacts. So tooth-to-tooth contacts that occur when the jaw are in any other relation other than centric relation. A straightforward movement of the jaw is called a protrusive movement, and then a retruded backward movement of the jaw is called a retrusive movement. I'm going to skip through this video, but you can watch this. It is linked in the materials and resources folder of this week 3 section, so be sure to check out the video there after you watch the lecture.
Hello everyone, and
Alright, restoration occlusion. So all restoration should be checked for premature or excessive high contacts in all directions. If a contact is premature, the restoration can put extra force against the tooth that is beyond the capability of the tooth and surrounding structures. So we want to make sure that the patient is not hitting too hard on a filling, especially a newly placed filling, or they're going to end up with a lot of issues. Ideal occlusion. So the ideal occlusal scheme is mutually protected occlusion. It's important to understand the role of anterior and posterior teeth within an ideal occlusion. So in the anteriors, the primary function is to incise or tear food and to protect the posterior teeth by separating them when the jaw moves into any of the eccentric positions. These movements can produce lateral forces, which are minimal and should not damage the supporting structure. For posterior teeth, the primary function is to masticate, chew, or crush food before swallowing and to support occlusion. They protect the anterior teeth. Rules of occlusion. So all marks on restoration should be equal to or slightly less in density than marks on other natural tooth structure. We definitely don't want it to be harder, like a more heavy mark, but we don't want it to be too light as well, because then it can kind of throw off their bite and the tooth may actually start to move in a different direction to try to get into occlusion. So heavier premature contact marks appear denser or as a halo of dense color with a center that is clean, almost like a bullseye. This kind of mark indicates that the tooth is contacting earlier or heavier than the other teeth. On posterior teeth, marks should appear as dots that are located on the cusp tips or fossae. So as you can see in the picture here, we see the dots of where these marks typically are on posterior teeth. And then excursive marks are marks that radiate from the centric marks during excursive jaw movements, so like side to side, we should get rid of those. These marks can be damaging to both the tooth and the restoration, so we definitely want to be careful with those and not keep those while we're doing the final occlusion checks. Rules of occlusion. So in general, it should not be our goal to remove all the marks from new restorations. The patient may not be able to tolerate the subsequent shift in tooth contacts to try to get into that intercuspal position. If the restoration is too polished out of occlusion, that tooth is going to want to shift up until it reaches occlusion. Teeth like to move until they're touching something else. So by not having any occlusion on a new restoration, or tooth in general, it can cause a lot of shifting. This can be a problem for the patient because they're going to have unstable occlusion. They may not be able to chew efficiently, especially if there's a gap and they get food in there. The teeth aren't going to be able to grind or chew there, so that's not helpful. Teeth can shift. And we always want to consider the opposing dentition, so the tooth opposite of the restoration, when we're checking occlusion as well. Working versus non-working cusps. So working cusps, for posteriors in intercuspal position, they are convex buccal cusp tips of mandibular teeth, which normally include into concavities, the fosses, or embrasures, like the marginal ridges, of opposing maxillary teeth, while the convex lingual cusp tips of maxillary teeth occlude with the concavities or embrasures of the mandibular teeth. So as you can see in the picture to the side there, you can see that the lingual upper cusp and the buccal lower cusp are kind of right in line with each other. So they're coming together there in perfect occlusion. Then we move on to the non-working cusps, and this would be the buccal cusp tips of maxillary posterior teeth and the lingual cusp tips of mandibular teeth, which do not occlude with each other. So as you can see in the picture, again, the buccal upper side and the lingual lower is not touching each other. They are kind of hanging out in their own little areas. So those would be the non-working cusps. So working, they're interlocked with each other. Non-working, they're just kind of out to the side, not connecting. Issues caused by premature occlusion. So lots of issues from premature occlusion, which we want to try to prevent. Things like excess tooth wear, tooth pain or sensitivity, especially when chewing. A lot of the times chewing harder things, nuts or hard candies, things like that, it can be extremely painful. Fracture of the opposing tooth or restoration, so it's going to be putting too many extra forces on the other teeth in that area. Movement shifting of a tooth or teeth, so if we're biting too hard on one tooth, it could cause that tooth to want to shift out of the area to be hit less hard. So that is not good either. Teeth are starting to shift, especially if there's a gap, say that there's a missing tooth from an extraction or just generally missing, it can cause that tooth to want to almost tip downwards. Widening of the periodontal ligament, which can cause loosening of the tooth as well. Interferences in the harmonious movement of the TMJ and muscles of mastification. This can lead to clenching, bruxing, which results in a lot of pain, and oftentimes this isn't a reversible pain. Patients are going to live most of their lives with this pain. Not good. So what are some procedures for evaluating occlusion? One, we want to sit the patient in an upright position, almost similar to how they would be sitting when they're eating dinner. If they're laying back, it can cause their jaw to open and close differently than if they're sitting upright. So we want them in their most natural environment of where they'll actually be eating. We're then going to dry the tooth and the opposing arch. So if the tooth is on the top, we're going to dry that top area and the bottom area as well. Articulating paper is not going to mark really efficiently if it's wet. Next, we're going to use the blue side of the articulating paper. Some articulating papers have a blue side and a red side. Some are just always blue. If there's two sides, we're going to use the blue side first and have the patient tap a few times. So just say tap, tap, tap. And any marks that appear darker than, especially on the restoration, any marks that are darker on the restoration compared to the adjacent teeth, make sure that we're polishing those so that they're even. Do not remove any marks of average density compared to the other teeth in the area. We want to keep them pretty even and the same. Next, we're going to use the articulating paper to recheck, keep checking until everything is looking even. Then we're going to check the excursive contacts by having the patient grind side to side and forward to backwards on the red side. We can adjust as needed without removing any blue marks. So then keep doing this. Every time you adjust something, we need to check again, because even if you removed some occlusion in one area, when you start to remove that, other areas could pop up as being too heavily occluded now. So keep checking until everything is even. And then after you're finished checking occlusion, you can wipe the teeth off with a gauze. It gets the marks off pretty well. Final criteria for occlusion. So first, we want to make sure that the restoration has markings that are similar in density to the surrounding teeth, the adjacent teeth. We want to make sure that there's no like bullseye type marks or any marks that are just much heavier density compared to the teeth around it. Everything should be looking pretty even. The restoration should be free of excursive contact. So when that patient is sliding back and forward and backwards, side to side, we don't want any of those marks on the restoration. And then lastly, the patient should feel comfortable. Even though they're numb, they should be able to have a good idea that everything is kind of lining up as it should be. If they're numb on one side, they can hopefully feel that the other side is contacting how it should be. And some patients, even if they are numb, they can just tell something doesn't feel right. They almost feel like they're biting into a seed. That would mean that they're not occluding properly. Notable exceptions. So number one, usually when restoring a tooth with a temporary restoration, there should be no marks on the restoration. It should usually actually be slightly out of occlusion. This minimizes chances of post-op sensitivity. It also helps minimize the chances of the temporary cracking, fracturing, breaking, anything like that. And then number two, when restoring an incisal edge or class 4 restoration on anterior teeth, the restoration should also just be out of occlusion in centric and excursive movements. This minimizes the chances of fracture during normal function. So kind of like when people are chewing ice or biting fingernails, things like that, if they are putting all that extra pressure on front tooth fillings, they're just going to keep chipping. So we usually want to take these just slightly out of occlusion in centric and excursive movements. So that back and forth, side to side is the excursive movements, just to protect those teeth from fracturing if the patient bites into anything. Tooth wear. So loss of tooth structure results from 3 basic physiochemical mechanisms. 1, stress. 2, friction, which can be attrition or abrasion. And 3, corrosion, which can also be erosion. These 3 mechanisms generally overlap each other to cause accelerated deterioration. First is attrition. So this is the gradual loss of tooth structure along the biting surface due to occlusal wear. Grinding and clenching of teeth, usually at night when the patient is sleeping, causes unnatural wear of enamel and can damage the periodontal ligament, associated supporting structures, and the TMJ. This is called bruxism. So bruxism is any clenching and grinding. Wear facets can also occur as well, which are smooth, worn areas on the occlusal or incisal surfaces of teeth, resulting from cuspal function during chewing or paris function. Usually indicates premature contact while the patient is chewing. So as you can see in the pictures to the side, the top picture is just showing that attrition from usually clenching and grinding, and then the bottom picture is showing those wear facets. So some people think that they are areas of decay or a filling popped out there, but usually no, it's just that dentin is exposed. It's creating a little well there of wear. Next is erosion, abrasion, and abfraction. This is tooth wear seen at the cervical third of a tooth near the gum line. It can be either, well, I shouldn't say either, all 3 of these options. And they all occur for different reasons. So erosion is believed to be due to a chemical process, usually acid. So someone who has acid reflux, or even like bulimia where they're throwing up a lot. This can cause these types of erosion areas along that cervical third. Abrasion then is wearing away of the tooth by friction, usually resulting from brushing your teeth too hard. So that's why it's super important to be gentle when brushing, especially around the gum line, so abrasion isn't occurring. And then abractions are usually caused by different forces. So the way that the teeth are biting together is causing forces that result in the tooth flexing there. And that's just the most weak part of that tooth where it's going to start to fail and create almost a wedge or V-shaped fracture in the tooth. So a lot of these times, like just a filling can be placed there, but you have to make sure the occlusion is good or else that piece is just going to pop out and the tooth will fracture there again. So usually just the result of needing occlusion adjusted a little bit. Next, we're going to talk about matrices and wedges. Alright, so a contoured and wedged matrix band is essential to prevent flat proximal contours. We want them to be a little convex, so flat, not good. It should come a little bit out so that way when we're flossing, the floss has some resistance to it. It also prevents improper contact and overhang as well. Matrix functions. So they can serve as a container into which restorative material can be condensed. So we can push the restorative materials against the walls of the matrix bands just to help condense them properly so there's no air bubbles or voids. They act as a temporary wall. They aid in restoring the proximal anatomic contours and contact areas and create a smooth external surface for the restorative material. There's lots of different types of dental matrices. We're going to get into a few here. Mylar strips, they are clear strips of plastic that go in between anterior teeth, typically using these for class 3 or class 4 restorations. And a wooden wedge is usually holding these mylar strips in place. Then we have a Tafelmeyer. They are assembled to fit a specific quadrant in the mouth and used for interproximal posterior restorations, usually for amalgam restorations. I don't find myself using this very often, especially not for composite restorations. There just are better options out there, but this is the most common matrix for amalgams. We have the auto matrix, which is a ring that goes around the entire tooth, and it's then tightened with a special instrument. You can use these for interproximal posterior restorations. Next, we have a sectional matrix. So this is a kit that comes with the ring clamp. There's different rings. There is a like a little pair of tweezers that can grab the metal bands and wedges that go in between the teeth as well, and they are used for interproximal posterior restorations. These are the sectional bands used with the sectional kit. There are multiple sizes available. Adults, usually they have like a molar size and a premolar size, and then also a kid size. Some have holes in the sides that allow them to be easily removed with the little sectional tweezers. Some don't, and I often find myself needing to use a hemostat to get the bands out if there are not holes present. And then we have wedges. So these wedges separate the teeth enough to fit in the matrix system. They hold the matrix band in place and help isolation as well. So these are the plastic ones. Usually for posterior teeth, I find myself using the plastic wedges. For anterior teeth, I find myself using wooden wedges. So getting more into wedges, they help seal the matrix and cavity interface where the matrix and cavity prep come together, which helps prevent overhang because if it's sealed there, that material is not escaping through the bottom of the matrix band and causing overhang there. It also helps the tooth separate just a little bit, enough to accommodate for the thickness of the matrix band. So that way when you take the wedge out, the teeth are apart a little bit. They're apart a little bit, and then the wedge comes out and the teeth can go back together again. It also helps with proximal contour. So again, teeth should not be flat in the interproximal area. They should be a little convex there, where they're coming out a little bit to meet where that contact point is. There's also wooden wedges. So wooden wedges are easy to trim with a scalpel to conform to the tooth surface. They are apparently more stable than plastic wedges because they swell when they come in contact with saliva, which causes them to expand a little bit, and that securely wedges them between the teeth. There are also plastic wedges though, which is, I typically prefer plastic wedges, like I said, except when I'm working on anterior teeth. They do have a small pin-sized hole to allow those pin tweezers to grasp them for more secure placement. There are all different sizes available, and the only downside with these is that especially the very small sizes can be very flimsy. They don't have enough rigidity to them where they can bend when you're trying to insert them in between the teeth. So that would be the only downfall, I'd say. But if that's the case, you just grab a new one or try one size larger. Matrix advantages. So they provide a controlled environment for restorations to be placed, allow for proper contouring and shaping of the restoration, aid in creating interproximal contacts, help prevent overhangs, which can lead to food impaction and gingival irritation, and they aid in aesthetics. Matrix disadvantages. There is a potential for distortion or displacement during restoration placement if the matrix is not properly secured. So if you don't have the matrix band on there very well, your filling's not going to turn out very well. The filling can get distorted if the matrix band is distorted. If it's not secured properly, saliva or blood can contaminate the filling. So these are all things we need to keep a close eye on. These matrix bands also may not perfectly adapt to all teeth surfaces, which can cause leaking around the restoration. It can cause blood and saliva to get in there, or even gaps like voids, air bubbles. Impact on tissues. So incorrectly applied matrices can lead to tissue irritation, especially if the matrix is too tight or impinges on the gingival margins. So we want to make sure that these matrix bands are not hurting the tissues. It's going to delay healing. It can lead to a lot of issues there with like food traps, things like that as well. So improper contouring does affect the health of surrounding tissues. Additionally, inadequate adaptation of the matrix can result in open margins, which leads to food impaction and recurrent decay. So if all of that food is getting stuck in there because the matrix band wasn't fit properly to the tooth, the patient's going to have a lot of issues, which are just going to keep building up. They're going to start getting food stuck. They can't floss out. They're flossing all day long, and that's going to cause bacteria to be attracted there, and eventually it's going to decay again. So matrix bands. Before selecting and placing the matrix band, you must examine the outline of the preparation. Proximal and occlusal portions may vary in size and shape, so we have to pick the right type of band. Characteristics of dental matrices. So you have to look for rigidity of the band. We don't want a band that's going to be very flimsy, that's going to move very easily. We want it to have a little bit of structure to it. Minimal thickness though. We don't want it to be super thick or else it's not going to fit in between the teeth. So it has to be strong, but stay relatively thin to where it's going to be able to slip through the sides of the teeth. Flexible. We do need it to be flexible because every tooth size, shape is different, so we need it to conform to the teeth. It needs to be compatible with the type of restoration we're doing. It needs to be stable, not moving around while replacing the restoration. And then optimal transmittance. So we want to make sure that we can still get a curing light to reach the contents inside of the band. So a Tafelmeyer, like I mentioned before, very common in amalgam restorations. I'm not typically using these for composite, although I've seen others do it. I'm just not a fan of Tafelmeyers. If you are, go ahead, use them for composites, but I am not going to teach you to use them for composites. I don't feel like they get proper contacts just due to how composite restorations are placed. Anytime I've ever tried it on a composite, I've just had not great contacts, and I like very tight contact points. So I am a sectional girly for composite restorations, but we will for sure be testing out the Tafelmeyers for amalgam restorations. There's various band sizes. So they have pediatric sizes all the way up to adult sizes. They have some extended bands for molar placements, lots of different options. And they are assembled to fit a specific quadrant in the mouth. So you do have to change these every time, like change where the band is every time you place a filling in a different quadrant. Next, we're going to go over all of the parts of a Tafelmeyer retainer. So first, number one is the spindle. This is the threaded rod containing a pointed tip. It can move through the entire length of the retainer and secures or loosens the band in that vice grip. So we're going to twist it up to lock that band into place, and then when we want to remove the band, we have to untwist that spindle. Next, we have the vise, which is a box-shaped device that has an opening for the threaded spindle to move in and out of it. There's a guide slot, which is located in the vise box. You can kind of see it in the picture there. Number 5, that little slotted area is where the band is going to kind of sit in there, and the spindle will grip into it there. Next, we have the head with outer guide slot, which is the very end of the retainer at the top, which can hold the matrix band in 3 separate positions, either to the right side, to the left side, or straight forward. Then we have the inner nut, which is number 4 in the picture. It opens the band or closes the band. So it's either going to make the band larger in circumference or decreases the circumference of the loop that the band is going to make to go around the tooth. And then last, number 3 on the picture is the outer nut, which tightens or loosens the spindle in order to either grip the band or let go of the band. Tafelmeyer guidelines. So, upper left teeth, the retainer head should be up, and the guide slot openings facing you, with the band loop on the left side of the retainer head. For lower left teeth, the retainer is head down, guide slot openings facing you, and the band loop on left side of the retainer head. For upper right teeth, the retainer head should be up, the guide slot opening should be facing you, and the band loop is on the right side of the retainer head. And then lastly, lower right teeth, the retainer head is down, the guide slot openings are facing you, and the band loop is on the right side of the retainer head. This will make much more sense when we are practicing in lab class. Tafelmeyer guidelines. So due to its boomerang shape, the loop has one opening that is larger in circumference than the other side. It's kind of hard to see in the picture here, but the side that is kind of facing towards the top of the presentation of this band has a larger circumference than the opposite side of it, which gets a little smaller at the bottom. This is kind of like how a tooth is, where it has a broader area towards the occlusal, and then as it gets closer to the gingival third of the tooth of the crown, it gets a little bit smaller in diameter. So that's why it's shaped this way. So the larger diameter opening adapts best to the occlusal portion. The smaller opening adapts better to the cervical portion. And then you don't want to use an instrument to round the loop before you are seating the matrix band around the tooth. It's just going to help contour better to the tooth. It's also helpful to burnish the matrix prior to placing it in the retainer. It just helps speed the process up and get more accurate interproximal contacts. So criteria for proper placement of the Tafelmeyer. The retainer itself should be adjacent to the facial surfaces of the tooth, so you don't want the retainer on the inside, lingual side of their teeth. You want the actual long part of the retainer to come out facially. That way they're still able to close their mouth and swallow and everything. The band should go 0.5 millimeters to 1.5 millimeters below the gingival margin of the cavity. So you don't want to end it right at the margin of where that deepest part of the interproximal prep is. You want to get it at least like a good millimeter below it. That way it's all properly sealed and nothing's gonna leak out and prevent and cause overhang. The band should also extend 0.5 millimeters to 1.5 millimeters occlusally, so higher than the actual tooth. That way it contains all the materials. You're not getting extra materials going over the band. It's gonna make sure that all of the filling material can stay inside the band when you get to that top occlusal portion. The matrix should be tight and stable, not loose at all. The band should not trap the rubber dam or any gingival tissues. The access to the prep box should be sufficient for condensing, so you need to be able to get all of your condensing instruments into the box. And then that narrower loop of the matrix is placed towards the gingiva, whereas the wider loop of the matrix is placed towards the occlusal. Improper placement of the Toffelmeier can result in open contacts, which causes food impaction, and then it can also cause displacement of the band during condensing. So when you're packing the material in, the band can shift, cause issues, break, come open, things like that, which can lead to overhangs. If an overhang is not corrected, it can cause gingival irritation and even possible bone loss. Not something we want. I'm going to go ahead and just skip through the videos here. You can find those in the materials and resources folder.
in this video,
Next is a sectional matrix. This is the most common posterior matrix for composites. So this is the one that I really like. It creates really good contacts. It's used for interproximal posterior restorations. There are, just like Toffelmeier's, various size bands available, from pediatric all the way up to adults. They are, in my opinion, at least the best way to achieve a strong contact point in Class 2 restorations. And a sectional matrix kit, includes forceps, pin tweezers, bands, wedges, and sectional rings. I'm going to just skip through this video because it is in the materials and resources section, so be sure to watch that next. And then we have the auto matrix, which again used for interproximal posterior restorations. Various sizes are available. It allows matrix placement and retention without bulky retainers. So you don't have like the big metal part of the Toffelmeier sticking out from the mouth, or even like the sectional rings. It's just kind of its own little system that there is the pin tweezers that's tight, almost coils them up to tighten the band. The kit includes the auto matrix rings, a tightening device, and snippers when you're cutting the band for removal. In my opinion, the contacts aren't the best with this type of matrix, especially compared to the sectional matrix. So I will use these typically when there are no adjacent teeth to a tooth I'm restoring. Like say there's just like number 30 all by itself and number 31 or 29 are not next to it. I'll use this because like the sectional needs an adjacent tooth in order to work. You could also use a Toffelmeier instead of the auto matrix, but I just feel like the auto matrix is a lot more user-friendly, easier to set up compared to the Toffelmeier. You can watch this video in the resources folder as well. And then we have Mylar strips. So these are used for interproximal anterior restorations. They are transparent, which allows for easy visibility during the procedure, and it can cure them effortlessly as well. Can be custom cut to size. So if you need a little piece, you just tear off a little piece. If you need a bigger piece, you tear off a big piece. Super customizable. And again, I'm going to skip the video and be sure to check it out in the materials and resources folder.